On to our next speaker, Dr. VARDHAMAN KANKARIA, who's again a very popular cataract, refractive and cornea surgeon and from Pune, and both nationally and internationally known. And he's going to talk on another very interesting talk, use of combined procedures with CXL in management of keratoconus.
Yeah. Thank you very much, ma'am. Ma'am, is my slide share visible?
Yeah.
So at the onset, I would like to thank Dr. Chitra ma'am for the kind invitation, and it's been a great learning session so far. Friends, what I'm going to talk to you about is going to be combination of collagen cross-linking with variety of modalities to improve the visual rehabilitation of our keratoconus patients. This all combined procedures together are called as CXL plus approach or collagen cross-linking plus approach. We all know that keratoconus is a progressive thinning disorder which results in corneal irregularity and resulting in irregular corneal astigmatism that leads to visual distortion and poor quality of vision for all our patients. It has been well proven that collagen cross-linking has been successful in stabilizing keratoconus in long term, but can we achieve more than just stabilization? So let's look at Swati, one of our first patients who came to us with progressive keratoconus, a low best corrected visual acuity of 20/80 and a moderate keratoconus. As you can see, she had a relatively thick cornea. So she underwent a standard Dresden protocol, and at 5 years of cross-linking, as you can see, she actually had a very stable cornea as seen in differential map and relatively flattened cornea, which made us very happy as doctors. So although as doctors, we were extremely happy, but Swati was not. And the reason was that she still had poor best corrected visual acuity and she was non-tolerant to contact lenses. Then we realized that many of these post-CXL patients do not achieve good functional vision, especially when they cannot tolerate contact lenses. And that is especially because of irregular astigmatism. So current therapy has to be both, that is not only stabilization, but also improving the visual rehabilitation of these patients by a combined approach. And this has been coined as CXL Plus by one of my mentors, Josh Quinones. So as we can see, collagen cross-linkage plus is a combination of collagen cross-linkage with variety of approaches such as transepithelial PTK, topographic guided PRK, phakic intraocular lenses, as well as intracorneal ring segments. And you have to really see and justify each and every case by case approach. So this is the first case. If you look at the 21-year-old patient who came to us with a relatively good best corrected visual acuity of 20/40 and a minimal to moderate keratoconus, a relative thickness of 483 microns. So back in 2009, our group led by Quinones had demonstrated that if we combine topographic guided PRK with collagen cross-linking at the same sitting, this combination therapy can be capable of offering patients good functional vision as well as stabilization of keratoconus together. This became very popular as Athens protocol. Further on, we published a long-term comparison between this Athens protocol in ophthalmology back in 2013, where we did a 30-eye randomized study between PRK CXL, which was the Athens protocol, as against the Dresden protocol alone, and looking at variety of outcomes. And we demonstrated a statistically better outcomes with the Athens protocol for both keratometric indices as well as the visual outcomes. You can clearly see the visual topographic stabilization and improvement that it brings in. But it is very important to note that this approach is not a refractive correction, but it is just to improve the therapeutic anterior surface, and minimum pachymetry of 450 microns and less than 50 microns of ablation is essential to look at this option. Let us look at, so with this patient, we did Athens protocol. As you can see, the patient demonstrated much better topographic outcomes and the vision improved from 20/40 to 20/20. Many patients have actually corneal thickness of which cannot be sufficient for Athens protocol because of very thin corneas. Therefore, the next approach was to see if we cannot do a topographic guided PRK, can we actually have epithelial removal technique in such a way that this technique itself helps us to improve the visual outcomes of collagen cross-linkage. So to look at that, we looked at a study by Reinstein et al. Who had demonstrated that the epithelium has a donut-shaped pattern in keratoconus, which is localized thinnest at the apex of the cone. And therefore, our group had hypothesized that if we use this differential epithelial mask agent, epithelial thickness as the masking agent and use PTK to evaporate this epithelium by about 50 microns of PTK. And then we can not only take out the apex of the epithelium, but also a bit of smoothing at the apex of the cone. We first published one case report. This was in European Journal, and in that you can actually see that there was this topographic flattening with the PTK, and thereafter we demonstrated in a comparative study between this approach, which was the PTK and CXL combination therapy, which is now coined as a Cretan protocol because it originated from the University of Crete, and versus the manual epithelial debridement. And we published that the Cretan protocol demonstrated statistically better visual as well as the topographic indices in long term, with none of the patients progressing. If you look at this patient had a very high astigmatism of about 15 diopters and low corneal thickness of 420 microns. So of course, this patient is not suitable for Athens as well as Cretan protocol. So for such patients of very high irregular astigmatism, it is important that we actually use an approach with the help of intracorneal ring segments. With intracorneal ring segments, which work as passive spacing agents in the periphery of the cornea and not only flattens the central cornea, but also improves the topography. So this can be combined with the same sitting or in two different sittings with collagen cross-linkage. In this particular patient, we used Intax, and as you can see, his topography had improved from 15 diopters astigmatism to 8 diopters astigmatism, and the visual acuity also demonstrated a base-corrected vision of improvement from 20/100 to 20 and 40. So this approach demonstrates the use of Intax with very high irregular astigmatism. Now we have looked at the cases with mild astigmatism, moderate irregular astigmatism, and also severe irregular astigmatism. So what about the eyes with very high myopia, but a mild irregular astigmatism? And we see a lot of such patients who are especially having central cones such as that. Look at this 27-year-old female patient who came with a best corrected visual acuity of 20/30, which was very good, but very high myopic astigmatism of -12 diopters of sphere and -4.50 diopters of cylindrical numbers. Of course, this patient was not suitable for any of the other laser combined approaches. Therefore, we performed a collagen cross-linkage, and after 6 months of stability, we performed a toric ICL implant. With toric ICL, the patient's vision improved to 20/40 uncorrected, and the patient was extremely happy. So it is very important with this combination approaches of CXL plus that you can actually individualize the combination of collagen cross-linkage with topographic added PTK, with topographic added PRK, which is called as Athens protocol, transepithelial PTK, Intax, as well as phakic lenses from case to case manner. CXL plus is definitely the way to the future, a method which offers a complete treatment of not only stabilization, but also improvement in functional vision of these patients. And this is very, very important that we customize the approach in such a way that we have a complete solution for our patients in the form of designing these approaches. So along with the Cretan, now we have recently submitted our paper for what is called as a Cretan plus protocol, in which we are doing a transepithelial PTK with a minimum PRK approach to improve these patients where they have insufficient thickness for topographic added PRK. So I think once the paper is published, I'll definitely share that with you all. Thank you again to Dr. Chitra ma'am and everybody else for the kind attention. Thank you.
Thank you very much, Dr. Vardhaman. That was an excellent talk. How many of us do a topo-guided PRK with cross-linking in this panel? Many of us?
Yes.
Yeah, there are quite a few of us. Then the first question I have to ask is, would you do a topo-guided treatment if the BCVA is 6/6, or only if the BCVA is compromised, would you do a topo-guided PRK with cross-linking? Any of you could answer.
Ma'am, if the patient is happy with the quality of vision and the BCVA is 6/6, I think probably I'll go ahead and just do a Cretan protocol for this patient rather than doing a full-fledged topographic guided treatment. Because many times with topo guided treatment, you have this kind of ablation where it steepens the flatter zone and it flattens the steeper zone. Many of the times you induce a lot of ametropias also along with that. So I think if the vision is 6/6, patient is happy with the quality, I'll just do a Cretan protocol for this patient.
Dr. Rajesh, would you think differently?
I would not do anything. If the patient is happy
yeah, that's
with his
true.
vision and is able to see very well, I would follow him up for progression of keratoconus. And if there is progression, maybe I'll consider treatment options. I have burnt my fingers over the years, last 15 years that I've been doing cross-linking and a combination of laser cross-linking. I've had patients who were plano for 3 years, and then later on they started becoming hyperopic. For the cases that I've done, a combined PRK with cross-linking. So I think there are a lot of unanswered questions. And so if there is basically if the patient is not requiring it and is happy with his vision, I don't think we should be running around and trying to do these corneas.
Yeah, I think I'll agree with Dr. Fogla. If it is non-progressive, I mean, first you have to look at this progression. If it is not progressing, I think it is best not to touch a 6/6 patient anyway. Yeah.
Yeah. No, that if
no
it is,
way 6/6 I think should not be touched at all. I mean,
no, if it is progressing or it is patient is going to have pregnancy and those kind of issues, I think it is knowing that doing a good topo-guided treatment cross-linking is definitely going to regularize any topographic irregularity too. I don't think we should categorize that way. If there is progression, there's no progression, yes, no. So anyway, the other question is, if there is progression but the refractive error is small, would you still do only a CXL, or would you think that this is the time when you could knock off that refractive error? And would you do a topo-guided treatment and do a CXL? Would you use a refractive cylinder as the correction, or would you use a topographic cylinder and axis?
Ma'am, if it is, before, I think Dr. Namrata ma'am wants to say something first.
no, I don't want to say something you say.
So basically,
no, I think if you want me to say, my take on this would be the same what Rajesh said. If it's a very small refractive error, then I will not, go running chasing it. I will again look for, progression in that case.
No, if there is progression, we are not talking of not.
There's progression, then collagen cross-linking would be done immediately. But I would not be very enthusiastic or very, aggressive about doing a topo-guided procedure on that patient.
Ma'am, because there is very, there are, I think, enough literature about very long-term flattening effects. Some of these patients have flattened to 4, 5, 6, 8 diopters. So if we actually try to knock off anything, there is a chance that the patient can become aggressively hyperopic in the future. Maybe again, in this case, my always balanced approach is, if it is progressing, I prefer a Kretan protocol if I have to combine it rather than doing anything else. Yeah.
I think those earlier studies were more with the standard cross-linking. With the accelerated cross-linking, where are we seeing in this last decade patients having excessive flattening? I'm somehow in variance with what you all are saying. Neither are we aggressive about doing it, but if there is a significant refractive error, moderately significant, if it is very significant, we would think of looking at intags. If it's moderate, then topographic asymmetry is there. Then when you're doing a accelerated cross-linking and regularization, all these patients are doing well. In this forum, I don't want us to go back thinking that that is a cancelled approach at all.
No, it's
watching
not
patient
a cancelled approach. But like I said, that this is not like the first treatment of choice when you see the patient.
Yeah.
Like even for me, if I can fix something by putting a intacs, I would look at that first, because that's a reversible procedure and that's something that you can, undo what you have done. But when you do a laser ablation and you're removing tissue from the cornea, then my primary objective is to try and address the astigmatism that the patient has. So it is not like a refractive correction. It's more like to reduce the coma or the hyoid aberration that the patient has, because of which the patient is unable to see with the spectacles. And it's imperative that all these patients should receive a contact lens. I see a lot of patients who have never tried contact lens and they're just looking for laser treatment and they want LASIK. And some of them, after I have, at least have them had a contact lens trial, have been so happy with the quality of vision. I don't think there is any procedure that can match the quality of vision that you can get with the rigid contact lens.
Absolutely.
So I think if the patient cannot wear the contact lens and then he understands the risks involved with the procedure, then we go ahead. It's an option, but it's not the first line of option in my patients when I treat. But definitely I have used it. I've used it in combination with cross-linking, accelerated cross-linking in combination with intacs. But these are patients who understand the risks involved with the procedure and, if there is an unpredictable outcome. And I never do both eyes at the same time. I've had a doctor, a medical student, whom I treated one eye, a topographic guided PRK and cross-linking. And I told her we'll wait for some time, see the response. And in that eye, she ended up with, +1 diopter hyperopia a year later. So the other eye, we just did cross-linking and we did not touch with the topographic guided laser.
Shreyas, are you there? Do you want to add anything? I think he has not got connected. Dr. Vikas, you have anything to add? You have to unmute yourself.
Yeah, I think same. If the patient has, what I see is what is the best corrected visual acuity with glasses. So if this best corrected visual acuity with glasses is 6.6, 6.9, and he's happy with that vision, nothing. So, and then next thing I ask is he happy with his contact lenses? Again, if he's happy with contact lenses, nothing. Then index only for generally for only for post LASIK ectasia or who has a steepening only in the inferiors, too eccentric, and you put only one ring. For cross-linking and TGPRK, so what I generally do is if the patient has low best corrected visual acuity, say 636, 624, for those only I generally use. So I think I'm quite conservative on that front.
So people who are on the cornea side are always more conservative, Chitra, as compared to people who
While we are on the subject,
I want Dr. Shreyas Ramurthy to use both cornea and refractive. I don't know why he is absent in this.
Chitra, definitely you have.
No, everybody is here cornea and refractive.
Chitra, definitely your group has a much larger experience in doing these patients. So maybe the volume of patients that you have treated, maybe once you have a larger volume and you have see better results, you have greater confidence in doing these treatments. But at the same time, let me disclose, I have now a series of about 8 patients. Out of that, 4 of them are doctors, and they have had cross-linking done 12 to 14 years before with the classical Dresden protocol. And all of them have exactly the same clinical feature of a non-inflammatory stromal tissue loss in the thinnest point, where they have lost almost the entire corneal stroma, resulting in requiring a corneal transplant. And this could be because there is, and the histopathology shows total loss of keratocytes. And this could be something that we are dealing with, that the collagen has lost its ability to regenerate. So that, the turnover of collagen is not happening. So the existing collagen, when it lyses, there is no new collagen being laid, and you just have the decimates, the pre-decimates layer and the epithelium. So in between, the stroma is just melting away, and it looks like a punched out defect. So it's not like a progressive thinning. So this is something, because we saw all these cases, now we are trying to compile it. This is something worrisome. And when I put this in one of the group, 8 other cornea specialists came up with a similar cases that they have seen. So I'm pretty sure if you go back, maybe you may have also come across a patient with very abnormal corneal thinning, post cross-linking. They all end up with very flat, cornea becoming very flat with 4 or 5 diopters hyperopia. And then this part of the cornea, the central haze, you start seeing this stromal loss. That is something because I'm pretty sure if this is it, then all the patients who have had the Dresden protocol, we may be seeing a much larger volume of these patients, these complications.
Dr. Fogler, do you feel that the MMC also we use in these cases, this has anything to do with this? Because
no, these are not topographic guided PRK. These are just cross-linking.
Conventional
Dresden protocol. They are all done in 2009, 2010, and some of them have been done at at institutes like SN at LVP. So it's not like they have done peripherally. So the machine was at fault. So they've all been done at tertiary care centers. So I'm pretty sure they followed the exact protocol. But the hypothesis I have is we know that the collagen turnover takes about 8 to 10 years when the new collagen is being laid. Maybe that original cross-linking has the stromal collagen has lost its ability to regenerate. So now what's happening is the old collagen in the thinnest area, as it's dying or it's getting absorbed, you don't have the new collagen being laid. And so the cornea is just thinning away and it's melting. But there is no inflammation, so it's a non-inflammatory melt.
Rajesh, I also have seen a patient recently with a similar clinical picture, procedure done with Dresden protocol 8-9 years ago, who has developed progressive thinning. The question is, I'm not very sure, at least I have not observed a similar change. Maybe we should go back and look at our cases. Do we see a similar change in the accelerated protocol as well? Because here,
none of these cases have had accelerated protocol. They've all had the classical Western protocol.
Probably even the conventional may not have been done in a regular manner, and they wouldn't have followed the protocol of a conventional too, for all you know, in those early days.
Accelerated is more recent, so we'll still have to wait for what will happen after accelerated.
Don't know.
Don't know. And I think, like I always felt in children, if you do collagen cross-linking, then the chances of, they progress despite that. But in adults, like you are saying, that the collagen is quite shocked and it completely just disappears.
Yes.